Hello, my name is Saul Weiner, and this is the sixth video in a series on contextualizing care. I've been looking forward to this one. I put it off for a bit because I wanted to cover some core topics first. But I'm often asked this question of, what are some of the differences and similarities between contextualizing care and social determinants of health? For those of you who've been watching this video series, you know that contextualizing care is a process of identifying and attempting to address the life challenges that patients are facing that are complicating their care. In contrast, social determinants of health has to do with a much larger set of challenges, such as poor housing, economic inequality, racism, challenges that can feel overwhelming to clinicians and can even perhaps elicit a sense of futility at the thought of trying to address them, and perhaps even some resentment. So while contextualizing care is certainly not a panacea, it does provide a practical approach to attempting to address the downstream day-to-day effects of these larger forces, one patient at a time. And when I've said it this way, I've sometimes been asked, so isn't that just like trying to put a Band-Aid on a problem? To which I've replied, yes, but there's a lot of evidence that wounds heal faster when they're covered. So with that thought in mind, let's get started. As we begin to delve into how these two concepts are similar and different, it's useful to start by reviewing some definitions. As you'll recall, patient life context refers to everything that is expressed outside of a patient's skin that's relevant to planning their care, and that's from the very first video. A key point is that this is a clinically focused concept that's intended to capture everything that a clinician needs to know and nothing more to help a patient who is struggling with a life issue that is complicating their care. So now, the U.S. Department of Health and Human Services describes the social determinants of health as the conditions in which people are born, grow, work, live, and age that affect a wide range of health, functional, and quality of life outcomes and risks. The term social risk factors refers specifically to those social determinants that may be associated with negative health outcomes, such as poor housing, economic insecurity, lack of access to nutritious food, and lack of transportation. And here the key point I'd like to make is that this is not clinically focused. Rather, it draws attention to the broad range of social issues that shape health. So now let's take these two definitions, these two concepts, and apply them to a particular case. Cheryl Jones is a 58-year-old woman with high blood pressure, on 2 medications, and a history of tobacco use, who has triple vessel heart disease and activity limited by chronic angina. She was discharged from the hospital 5 weeks ago following admission for management of a myocardial infarction. She is on several new medications. Her heart disease diagnosis was delayed a year because her main symptom had been shortness of breath, and her doctors didn't think it was cardiac. At this stage, her cardiologist recommends a CABG, that's a coronary artery bypass graft, which she has thus far declined. She's been referred to you as she needs a general primary care doctor. Her blood pressure is not well controlled, and she's missed 2 prior appointments scheduled with you before making it to this one. And I've added a note here for context that this is from December of 2020. Now, the audio coders would have extracted 3 contextual red flags here. First, that she's losing control of a chronic condition. Second, that she's having trouble making it to appointments. And third, that she's declining recommended care for a symptomatic serious condition. So let's jump ahead here, assuming our clinician probed each of these red flags, and this is what they learned. First, that Ms. Jones cares for her 66-year-old husband, Ray Jones, a U.S. Navy veteran who suffered a stroke 6 months ago while recovering from COVID. He needs help with many activities of daily living, including transferring from bed to chair and bathing. She's his only caregiver and sometimes misses her appointments when helping him. She and her husband had owned a small trucking business in which they leased and drove trucks and employed 4 other people. He had been unsuccessful in obtaining a loan to purchase his own vehicles as banks would not lend, and his attempt to obtain funds through the COVID Paycheck Protection Plan, or PPP, had also been unsuccessful. The employees had been laid off. Paying leasing fees resulted in considerable financial and personal stress and risk of foreclosure on their home. Ms. Jones needs health insurance after losing a small business group plan and has applied for Medicaid. Medicaid will retroactively pay her medical bills. However, she's not been able to afford to take her medications daily. Ms. Jones is distrusting of the healthcare system based on personal experience. 6 years ago, when her husband was recovering from a back surgery after an accident, she saw him suffer because his physicians did not adequately treat his pain. She does not want to go through that with her own surgery. She attends church and prays, saying, "I'm in God's hands." She's also frustrated that they only diagnosed her heart problems after she had a heart attack. They had thought her shortness of breath was just due to weight gain. She mentions she's not eating well. In recent months, without income and with increasing debt, she relied on a food bank, but there were long lines. It was difficult to get there early enough to get fresh fruit or vegetables. Most of what was left was canned or processed. So our coders would extract the following contextual factors from that narrative. First, that she has distrust of the healthcare system, resulting in declining needed care. Second, that she's experienced a loss of health insurance, resulting in medication non-adherence and loss of control of her hypertension. Third, that she has caregiver responsibility for her husband, resulting in missed appointments. And then additionally, a lack of access to healthy food and a lapse in insurance coverage. Notice that the first three were identified in response to probing a contextual red flag, and then the final two simply emerged during the course of the conversation. These are what we would call spontaneously revealed contextual factors that occurred without a probe, something that we talked about in prior videos. So let's take a big picture look at what's going on here. At the top, we see social determinants of health, specifically social risk factors. If we look from the bottom, we see contextual red flags. Right above these contextual red flags are a set of contextual factors relevant to planning the patient's care. Now, when you put it all together, there's probably a certain amount of overlap. I would defer to others who are more familiar with the literature on social risk factors as to what they would include or exclude. I think the key point here is that the social determinants of health, specifically the social risk factors, are the high-level or social forces that are driving what the clinician is seeing and what the patient is experiencing. And it's helpful, I think, to look at this both from the top down and from the bottom up. So, at the top, I've identified racism, both institutionalized and perhaps personally mediated. Ms. Jones and her husband happen to be Black. Now, we talked about the failure of the small business to survive the pandemic. They'd been unable to get small business loans even before the pandemic, and then during the pandemic, they were unsuccessful. And there's a lot of evidence that Black businesses disproportionately went through this and had this kind of experience, again, both before and during the pandemic. On the right side, we see the effect of the undertreatment of pain in her husband, again, something that's seen more commonly in the care of Black patients, and the delay in the diagnosis of her myocardial infarction with the delay in the cardiac catheterization, something that is more common in the care of women. We in turn see how that experience shaped her fear and distrust of the healthcare system. Looking back to the small business failure on the left, we see in turn how that led to financial insecurity, a lapse in health insurance coverage, and food insecurity. So we get a picture here of how these larger forces are pressing down and causing stress on Ms. Jones and her husband. If we turn now to the contextual red flags, which are in red, we see something quite different from the clinician's perspective. It appears here as almost as if a patient is behaving irrationally. They're declining recommended surgery, they're not taking care of their chronic condition, they're missing appointments, and so forth. However, the clinician who approaches this from a contextualization of care perspective will probe. They'll begin to ask questions, and that will take them one layer up at least to identify the contextual factors which will be relevant to planning care. The fear and distrust, the unhealthy diet, the medication non-adherence, and so forth. The clinician can't do much about the fact that the business failed because it was subject to unfair lending practices, but they may be able to help in more specific ways by mitigating the contextual factors. For instance, helping Ms. Jones identify respite care services that are available in the community, providing Meals on Wheels services, and allying with her around her unfortunate experiences or the experiences of her husband with the healthcare system in order to regain her trust. That's what we mean by contextualizing care. The National Academy of Medicine, in its 2019 report Integrating Social Care into the Delivery of Healthcare, Moving Upstream to Improve the Nation's Health, conceptualized a framework for action. What you can see here on the top are activities focused on individuals, and beneath that, activities focused on communities. In brief, the top two are things that can be done during a patient encounter. An adjustment is a change in clinical practice to accommodate existing barriers, such as switching a patient to a cheaper generic. Assistance is connecting a patient with resources, like a transportation voucher. These are both strategies for contextualizing care. The bottom two, however, require a community-level intervention. Alignment is when a healthcare institution engages stakeholders to enhance social care in the community, for example, by supporting local infrastructure investment. Advocacy activities promote social change that will improve health and address social needs in the community. So these are strategies that fall outside of the scope of contextualizing care. There are a few other differences I'd like to highlight. First, that contextualizing care is broader than just addressing social risk factors. So for instance, poor vision or arthritic fingers are contextual factors for not being able to take insulin as directed, even if you're a wealthy and privileged patient. A physician attentive to contextualizing care would address these, even though they may not be linked to social determinants of health. Second, contextualizing care is broader than adjustment and assistance. So for example, identifying depression as the reason a patient has stopped taking their diabetes medication, the context, and intervening to treat the depression would be a form of contextualizing care, even though it doesn't require specifically assistance or adjustment. And finally, contextualizing care is measurable and predictive of improved healthcare outcomes. We know that because we have the 4C coding system to assess it. Now, there is no 4C equivalent for determining whether social determinants of health have been addressed. However, as I pointed out, some of the activities in the National Academy of Medicine's framework for responding to social determinants, specifically adjustment and assistance, are part and parcel of contextualizing care. So 4C would certainly apply to assessing those aspects of attention to social risk factors. In summary, here are a few key points. Contextualizing care is a practical and evidence-based approach to helping patients address barriers to health during the delivery of healthcare, regardless of whether there are social risk factors. It empowers physicians to address social risk factors as part of a general approach to patient care. Physicians who seek to contribute more broadly to addressing social determinants of health may engage in social justice advocacy in their communities and beyond, but doing so is outside of the scope of clinical practice. I hope this brief comparison of these two concepts helps clarify how they are similar, different, and complementary. As always, thank you for your interest.